Welcome back, aspiring medical coders. You've made it to part 20 of our 100-part CPC exam series. I am so incredibly pumped to be your ultimate exam coach today. We're diving straight into some of the absolute highest yield guidelines you're going to face on test day. But right before we unlock these exam secrets, make sure to like, share, and subscribe to Decode Healthcare with Harshal. It helps us keep this free series going and ensures you never miss a critical update. All right, let's kick things off with our first domain. Section 1, Endocrine and Diabetes Rules. This is easily one of the most heavily tested areas you'll see. So, your very first decision point as a coder, determining the exact type of diabetes. We've got type 1 diabetes, coded in the E10 category. And then we have type 2 diabetes, which falls under E11. Now, remember this rule of thumb. If the provider's documentation doesn't explicitly specify the type, the default guideline is always to code type 2, E11. Simple as that. Now, what about complications? This is absolutely crucial, folks. You've got to use combination codes. Let's say a patient has type 2 diabetes with a foot ulcer. You do not code the diabetes and the ulcer separately. No way. You use a single combination code exactly like E11.621. Never, ever unbundle symptoms when a single combination code exists. That is a massive exam trap that catches so many test takers off guard. While we're still in the endocrine chapter, pay really close attention to obesity code distinctions. There's a huge clinical and coding difference between E66.9 for unspecified obesity and E66.01 for morbid or severe obesity. To use E66.01, you literally need clear provider documentation stating that the morbid obesity is specifically due to excess calories. In medical coding, precision is everything. Moving right along, let's dive into navigating the circulatory system. This chapter is absolutely packed with high-frequency codes you'll see on almost every single CPC exam. We absolutely have to start with I10, essential or primary hypertension. This code is a massive exam staple. But hey, a quick warning here. If the medical scenario documents that the hypertension is linked to heart or kidney involvement, you can't just force I10 as your answer. You actually have to follow the specific combination guidelines for hypertensive heart or chronic kidney disease. So keep an eye out for that. When it comes to heart failure, vague coding just won't cut it. You have to hunt through that documentation for exact terminology. First up, what type of failure are we looking at? Is it systolic, diastolic, or combined? Second, what's the timing and clinical severity? Is it acute, chronic, or maybe acute on chronic? Your final code selection hinges entirely on those specific descriptors. And this brings us to the stark differences in stroke coding. Hemorrhagic strokes, those are active bleeds, fall into the I60 to I62 range. Ischemic strokes, which are caused by blockages, are I63. But here's the real trick. If a patient is being seen for the late effects or residuals of a past stroke, you must use the sequelae category, I69. Differentiating between an active stroke right now and a historical one changes the whole shebang. Next up, injuries, fractures, and burns. This section is notorious for rigorously testing your attention to encounter logic and external causes. Now, what's really interesting here is the critical X placeholder rule. For injuries, the 7th character extension is simply non-negotiable. A is for the initial encounter, D is for subsequent encounters during routine healing, and S is for sequela. If your base code is only 4 or 5 characters long, you literally have to use an X placeholder in those empty spots just to push that A, D, or S into the 7th position. Without it, your code is totally invalid. Let's rapid-fire the must-know fracture specificity checklist. You need to identify a few things. Is it open or closed? Displaced or non-displaced? What is the exact site and bone? And what's that 7th character encounter we just talked about? Also, remember the golden rule. If the doctor's note doesn't specify displacement or open versus closed, the default rules in the code set typically point to closed and displaced. For burns, severity and code sequencing are entirely driven by the depth of the burn, the exact anatomical site, and the total body surface area or TBSA percentage involved. And always sequence the code for the highest degree of burn first. Let's move right into our next section, poisoning versus adverse effects. This is a notorious exam trap, so pay close attention. Clearly separating these 3 buckets is absolutely vital. Poisoning means something went wrong with the usage itself.
It's an overdose, the wrong drug, the wrong substance, or the wrong intent. An adverse effect, however, means the patient did everything perfectly right. The drug was prescribed correctly, taken correctly, but a bad side effect still occurred anyway. And underdosing? Well, that means taking less than prescribed, which leads to a relapse or a worsening condition. Make sure you keep these categories locked in.
Wow, we've covered some serious high-yield ground today. Let's bring it all together for our final section, the Part 20 cheat sheet. I highly recommend you hit pause and take a screenshot of this one-page visual summary, synthesizing the whole explainer. For endocrine, always use combination codes for diabetes with manifestations. For circulatory, verify your heart failure specificity and stroke type. For injuries, remember that the 7th character is non-negotiable and use your X placeholders. And for poisoning, always differentiate the exact intent and usage.
You've completely crushed the high-yield rules today, but ask yourself this. If a single missing X placeholder can invalidate an entire claim, what other hidden traps are lurking in your coding? We're really just getting started. Coming up in Part 21, we're tackling Z codes, external causes of morbidity, and common diagnosis audit triggers. Keep studying hard, stay focused, and I'll see you in the next explainer to continue conquering your CPC exam prep with Decode Healthcare.